Good morning, good afternoon, good evening to whoever is watching this video. Welcome to ASAP Conversations. In this episode of ASAP Conversations, we will be talking to some of our members and partners from groups that work with doctors and medical professionals, specifically related to safe abortion rights advocacy. So I'm now going to request them to introduce themselves. I'm Suchitra Dalvi. I'm a practicing gynecologist and also the coordinator of the Asia Safe Abortion Partnership.
Hi, I'm Riccis from Mumbai. I'm a medical intern and I'm also the co-founder of the India Safe Abortion Youth Advocates, where we sensitize medical students to continue the advocacy.
I'm Polly. I live in London. I'm a junior doctor and I'm treasurer and until recently content creator for Doctors for Choice UK, which is an organisation which campaigns for the decriminalisation of abortion in the UK, as well as raising awareness and destigmatising abortion.
I'm Corinna. I'm also from London. I'm a junior doctor currently doing a master's in reproductive and sexual health. And I am the head of education in Doctors for Choice, which includes Education for Choice, which works with medical students to teach them more about abortion provision.
That's wonderful. Thank you very much, all of you, for taking out the time to join us here in this conversation. So my first question is to both the countries. As far as I'm aware, abortion is legal in the UK as well as in India. So how does it matter whether it's decriminalized or not? And why did you then need to set up these organizations? So maybe if we could ask Riccis first and then...
Yeah. In India, it has been decriminalized since 1972. But even today, we are seeing a lot of mortality regarding abortion. And because of unsafe abortions and the access with abortion is really restricted, even though we have a fairly liberal law in paper. There are issues like the opinion of the doctor is like at a higher stand than the choice of the woman to seek an abortion. So it creates a lot of hurdle. Then there is also the point where you have centralization of all the resources and information in most of the urban areas, whereas most of our population lives in the rural places where you don't have enough healthcare services. And there is also the stigma, which is regarding giving women the autonomy to decide for themselves, forget about abortion, even with contraception, and so much stigma around just anything regarding women's health and sexual and reproductive health and rights.
Okay. Sounds like you have quite a challenge ahead of you. Would you like to tell us some more, Polly and Corinne?
Sure. So in the UK, actually, abortion's not decriminalised yet. We have a 1967 Act which gave doctors a
medical defence to provide an abortion if certain criteria are met.
Exactly. So there's 5 criteria which have any of which can be met, and then people can access abortion. But that requires 2 doctors' signatures on that form, which obviously has its own restrictions for people accessing care, and we think contributes to the stigmatization of abortion. So I think until that, the original law, which was from the 1800s, which is just crazy, until that law is decriminalised, then I think only then can we truly believe that abortion is decriminalised in the UK.
It also means that when you want to try and make small changes in the way in which abortion is provided, it's required to go through government for those changes to be made. So, for example, with COVID, it became much more difficult to provide face-to-face abortion care. So lots of places that provided abortion wanted to start providing telemedicine. Mm-hmm. And in anything other than abortion, that would have been able to be decided by the medical bodies. But actually in the UK, in England and Scotland and Wales, it had to go through the government, and it wasn't immediately put through, and it took a bit of time for that to pass. And in Northern Ireland, they still haven't been able to access telemedicine. So the fact that those controls are still put in at a government level means that it limits any progress in terms of abortion provision that could be made from a medical perspective.
Right, right. It's very interesting actually, and quite fascinating that India also has a penal code, which was sort of the British Penal Code of 1860s, which was absorbed by India, sort of taken on after independence. And that also criminalizes abortion or the causing of miscarriage. It criminalizes the woman as well as the provider. And just like your act of, 1967, so we have an act of 1972, which Riti spoke about, which again, allows under certain conditions. So it's not a rights-based approach. It's protective for the doctor against the criminalization. And it's always fascinated me as a gynecologist that there is no other medical procedure which is protected by a law of parliament. So clearly, this kind of protection or criminalization emerges from ideological positions, nothing to do with medical technology. And as you said quite rightly, as technology advances and we want to make things easier and better and decentralized, it's impossible to do that without going through parliament. So it's a really fascinating history. You spoke about Northern Ireland. I also wanted to ask if you have any experience of what is happening in Ireland itself, because recently they had a lot of upheaval around the abortion law after Savita's death, and if there's anything you want to reflect on, were you involved in any of the work there?
So in Ireland, they were their law was based around the amendments, and the 8th Amendment in Ireland prevented abortions being legal. And as you mentioned, Savita Halappanavar died in 2012 because she couldn't access abortion care when she needed it. And I think that really kind of got the ball rolling in terms of politics in the UK and Ireland, because people were outraged that somebody could die from something when, which is so preventable. So we actually there was a group of doctors there, mainly GPs, called START, and they started the campaigning around long before the 8th Amendment was repealed, because they thought that, if they could get a big campaign going and train themselves before the 8th Amendment was repealed, then they'd be ready to get going as soon as the law allowed them to. So we had one of the original GPs come and speak at one of our conferences a couple of years ago, Marion, and it's just really inspirational to hear what they've done. And Northern Ireland, I think, have kind of taken a leaf out of their book, and even before Northern Ireland decriminalised abortion recently, we were going over there and holding events, training events, and really trying to replicate that kind of from the ground approach that Ireland, the Republic, had as well. And they really were a success story. It is amazing that they got out there, they got the messaging out, they encouraged people who were from Ireland to come fly back and come and vote to repeal the 8th Amendment. So yeah, it's inspirational, I think.
It has been extremely inspirational. And speaking of the work that you did as a result of your involvement in this, it sort of leads me to my next question about what is it exactly that you do as Doctors for Choice and as I Say. If you could just tell us a little bit about your activities and what is the mobilization include.
Corinna, do you want to talk about education to start?
Yeah, sure. So we do lots of different things as Doctors for Choice. We campaign for decriminalisation and destigmatisation of abortion. And one of the key things that we do as Doctors for Choice is our educational programmes. So we think that it's incredibly important to provide unbiased, non-judgmental abortion education at every level. So with Education for Choice, we train medical students to go in and teach secondary school students about contraception and abortion care. The sexual health curriculum here is variable. There is a new curriculum coming in this year, which we hope will improve it. But previously, it's been very school dependent. So if you happen to go to a school that has a really good sex ed, you might get some abortion teaching. But certainly the school I went to, and when we run our sessions, it seems like you don't generally tend to get anything at all. So we try and counteract that. We run sort of 40 to 60-minute sessions. They're very interactive. We run them with relatively small class sizes, and the feedback has been really brilliant. Most of the children, they're sort of 14 to 17, and they are thinking about their sexual health, and which is brilliant.
Yeah.
And we kind of start with the contraception, so present them with preventative measures, but then also want to make them aware that abortion services are available, and to destigmatize, and sort of, we think raising awareness is a key part of the destigmatizing process. And then also so one of our co-chairs is the head of the abortion teaching at one of the medical schools in London. And me and Polly both went to that medical school, so we both had the brilliant teaching, and I think I can speak for both of us in that it inspired both of us to get more involved in sexual health and abortion care. And so she's developed a really sort of brilliant curriculum that now is at the stage where it can start being taken to other medical schools. Yeah.
That's fantastic. I mean, a good teacher can make such a difference in so many lives. And I think that kind of takes me on to the next question, because I know that Riccis has had an article published in a journal where she analyzed the misogynistic language in medical textbooks. Because as you mentioned, both of you were lucky enough to have a teacher who inspired you. But it really shouldn't depend on luck, right? Everyone should have a chance to have that kind of conversation, which is, as you said, gender sensitive, rights based, without any stigma underlying. So maybe if Riccis could tell us a little bit more about that article she wrote, and talk a little bit about what ISAE does with medical students.
The article is basically, the title is Gender Perspective in Medical Education, and the aim is to analyze the medical curriculum through a gender lens. And it just goes on to talk about how the language that the textbooks have been using. And while I was going through it, I found so many the words which women's health is mainly spoken under maternal and child health, and women are always seen through the patriarchal framework of the society. And even when talking about a pregnancy, it is always the baby, and they miss, or it's just like a habit, but they do say baby instead of fetus. And so many times we under the section of contraception, it's always under family planning. The only way to talk about contraception, we see it under family planning, and there's just no other way. And even the textbooks which are supposed to be the go-to for us is they don't speak about gender-based violence and things like nutritional deficiency and how they stem from. And instead they just put it as facts, and without putting any context in. It doesn't matter, the facts don't matter if you don't put context in, because that's not how we will improve women's health or public health in general. And at one point they actually stated there, if there is a young couple coming to you for abortion services, it is better to sit with them and talk it out with them, do they really need an abortion, or
encourage them to continue, basically.
Yeah, it's a good choice to continue with the pregnancy because they are newly married, and it's time for kids, and just the things that the stereotypes that we have, once marriage is done you need to have kids, and there's a timeline that we follow, right? So there, and things like virginity and rape, but it's only rape when it is when it happens to a woman, or sexual assault. These things are not really spoken about in our textbooks, and it's kind of sad because this is kind of the sensitivity you need to provide young medical students who are going to be doctors, and break the cycle of the stigma and make sure that they are the ones who are providing non-judgmental services further. And even the facts that we are reading in our textbook, most of them are about women's bodies, are research that has been extrapolated from the male-based research, because women were allowed in clinical trials a lot later than men. And it was just that even when they were allowed, they were if they are under childbearing age, so that's majority of the women, and they were exempt from entering clinical trials. And even today in 2020, there is yet a lag, and there is disproportionate inequality when it comes to representation of women in clinical trials. So these were just things that we read about, but we don't see in our textbooks. And I didn't have good professors in my college who spoke about all this, but there were professors who said things in front of 200 people that contraception is unnatural. And you just think that how do you approach such a faculty with the work you do. And coming to the work that we do, so we are a group of medical students, and the work is kind of similar to yours. And what it is we do sensitization workshops where we talk about gender, sexuality, and then come to contraception and abortion, because it is important to know that they are not safe abortion is not isolated issues with gender or sexuality. They have a huge impact on how women or pregnant people approach safe abortion services, how they are able to approach them, what are the barriers facing with accessing safe abortion, and just so on. And we also have a social media page where we do campaigns and just have regular posts with busting myths. And on even on a college campus, we have started various conversations with everyday sexism and the things that happen. And I think it has been pretty good, and we are regularly making changes to how we approach students. And just it is really important that medical students are sensitized. And since they are one of the influential people in the community, and without sensitizing them, it is almost impossible to have health equity when we are talking about just healthcare in general, and not just safe abortion services.
Yeah, you're absolutely right. Thank you, Riti, for sharing that. And I think ISA has always been very creative in its outreach. I know that you were nominated for an award for a social media campaign last year. And we saw, of course, the wonderful video that Doctors for Choice just made. We've been sharing it widely on our social media as well. And when we post this video, we'll include a link to that so that people can have a chance to see that creativity. Riti, as you were speaking about, women not being allowed in clinical trials, I was just thinking that the four of us sitting and talking here would not have been possible 100 or 200 years ago, when women were not allowed in medical colleges. So I don't know if you all have read the booklet on witches, midwives and nurses, where, the witch hunts kind of destroyed a whole generation of women healers and replaced it with this so-called modern medical system. So it's no surprise that it's not gender sensitive or women centered, because it's emerged from roots which kind of, destroyed the women healers. And there are some, I think, documents from Harvard probably, which say that women should not be allowed into medical colleges because their brains are too small. And if they undertake rigorous academic work, their ovaries may stop functioning. And, if a woman can't reproduce, then what use is she, kind of thing, which just sounds hilarious right now. But there are still so many challenges. As Riti said, virginity is part of the medical textbook. Why is virginity in a medical textbook? Why is it an issue? So why are these social, cultural aspects of patriarchal control not being spoken about? So I think it's amazing the work that everyone is doing. So I wanted to ask you, in the context of the current pandemic, what are the issues that you are seeing in terms of access? Because we know that very often doctors themselves are seen as one of the biggest barriers. As Riti said, very often they counsel the women to just continue. I don't know whether conscientious objection is a big issue in the UK. And if that is affecting access even right now in terms of the pandemic, and public sector and private sector services. So if you could just talk a little bit about that, maybe. I don't know if Polly wants to go first.
Sure. So conscientious objection is written into the UK law. So doctors have a right to opt out of providing abortion care, but they still have a the usual professional duties to make sure that someone who needs to access care can. So we always teach, it's interesting talking about language, because we teach about the difference between conscientious objection and conscientious obstruction, and how those two things aren't the same thing. And if someone does actively try to obstruct a woman or a person from accessing abortion, and dissuade them, that's against GMC, the General Medical Council regulations. So I think the sad reality is we don't hear about all of the cases of conscientious obstruction that are going on in the country, and occasionally a case will come to light and it will be in the papers. However, I do think we've been relatively lucky in the change of short-term law that COVID's brought about with telemedicine. As Corinna was saying previously, the original 67 Act said that the abortion had to be provided in a registered facility, so usually that was a clinic or a hospital, and then we took it a step further about a year or so, just over a year ago, when misoprostol, the second tablet for medical abortion, was allowed to be taken at home. So that meant the person could travel home and take that home without the risk of having an abortion on the way. So now the new COVID legislation says that somebody can have an abortion at home. And so telemedicine is allowed. So they have to have a consultation on the phone with a medical professional, but they are allowed to have that abortion at home. And I think from what I've heard from services, it's really revolutionised how they're practicing. I think for a long time, people knew that telemedicine worked, and there's people like Women on Web who have been practicing that in countries where access is really difficult for a long time. And in fact, even women in the UK were accessing Women on Web just because they couldn't get an appointment, for example. But yeah, so I think that's been positive, but obviously it goes without saying, people who are in homes where it's difficult, they might be in an abusive relationship, or their family might not know about their position. I think that's really difficult, and I don't know how we get around that other than to try to provide contraception where possible. And I know that one of the independent abortion providers here are selling emergency contraception online, and I think that's a good initiative really for people who might find themselves in a difficult situation.
Right. So just a clarification question, Polly. Regularly, pre-pandemic, abortion services in the UK are available through the NHS, or do people have to go to a private provider and then it's paid for by the insurance? How does it work? If you could just explain.
So it's paid for by the NHS, but most of them are done in independent settings. So one of the major ones is called the British Pregnancy Advisory Service. So it's not private because the NHS outsources those clinics, but it's just because there's not NHS facilities as many as these independent providers who are set up, and they run really well. And obviously that poses an issue for training, because it's really difficult to get any training in abortion care if you're not in a hospital that's lucky to have a clinic. So,
but is it also a kind of systematized, well, not stigmatization, but othering, to have, to go to some other place for abortion, whereas everything else is in one hospital? So is there any, is that part of your strategy to try and integrate the abortion services within women's health services?
Yeah, absolutely. And I think, BPAS themselves want that. They kind of want to, they campaign to get themselves out of a job. That's what they say. But I think the good thing is that they do provide an excellent service. So, that is at the forefront. It are the patients and the people who need the services. But yes, ideally, we would integrate.
That's very interesting to know. Yes, Corinna, do you want to add something?
Yeah, I just wanted to add a little thing beyond sort of getting it integrated into women's health services. As early medical abortion is becoming more and more widely used in the UK, it's definitely more of a campaign to get it included in GP services as well, because currently GPs aren't a registered place, so they can't deliver any abortion provision at all, with the exception of Northern Ireland. So in England, Scotland and Wales, you have to either go to a women's health facility in the NHS or an independent provider. And as you say, that really creates this othering environment. And an early medical abortion could easily be provided by a general practitioner who you go to for all of your other sort of regular needs. And that's definitely something that Doctors for Choice is pushing for, as part of decriminalisation, to allow abortion care to be undertaken by GPs.
In fact, some of us are now starting to advocate for self-managed abortions, saying that women are managing so many, I mean, people are managing so many things for themselves nowadays, like diabetics are managing their testing as well as insulin. Women have been managing their own miscarriages and even births for, millennia. So with the advent of medical abortion, as you say, telemedicine is one step, but potentially self-managed abortion would kind of be the next step. So that's good to know. Thank you. Riti, do you want to tell us something about what's happening with access to safe abortion in public health sector currently? Because I think you're working as an intern in a public health sector hospital.
Yeah, so as of now, because of the pandemic, most of the OPDs and all are shut, and even the abortion has been like termed essential. Uh, it is yet creating a major hassle to access a public health center, because that means you have to get out of your house, find transport. All the transport, public transport, has been shut, at least in Mumbai right now, and to go there, and then even after that, you have to there's always the panic that once you go out, you're going to get infected, or going to a public healthcare facility where already so much testing is going on, and there are the numbers are skyrocketing. There is it is yet difficult to find it, but it really depends on the doctor sometimes. If you get a good doctor, if if they are willing to provide you with an abortion without making you wait, or making you come for a next visit, it's really good. But sometimes that's not always the case, and the thing is, the public health sector is right now really overwhelmed, and not a lot of private clinics are yet open, so that is creating a major hassle. People who used to go to private healthcare sectors for seeking abortion or just any healthcare services, they are not able to go there, and because of that, everyone is going to the public healthcare sector, and there's also a lot of reluctancy to step out of your house, so that's creating another hurdle. So that is there, and with that, we've also had a couple of people contact us saying that they have unwanted pregnancies and they would like to terminate. And it's just creating so much of an issue, sometimes the partner knows, sometimes they don't, or what if the person is unmarried and they can't speak to anyone in their family. It's just making it more and more difficult to give a reason to get out of the house, and the situation really varies for the person. And as of now, ma'am said, and the condition in the UK too, it would really help if the nurses and midwives and other healthcare workers, apart from just doctors, are trained for this. So we could come up with more solutions, because basically what this pandemic has shown us is to become more creative with how we are providing healthcare, how people are yet being covered or yet being treated. And it would really help. I've seen people put up listing for consultations online, so why not the same for abortion? Even though the pandemic is going on, you're yet supposed to go for the first tablet to a medical facility, and you can take the second one at home, but it is yet a barrier nonetheless. So it's yet getting a little difficult, and the lockdown is kind of unpredictable. It's just being extended for months and months, and do not blame that on anyone, but yet it is just difficult it's making the scenario more and more difficult for women trying to do abortion.
Actually, what you're saying, Riti, reminds me of a quote I often like to refer to. It's from Rudolf Virchow, who's known as the father of pathology. And that's a whole different conversation as to how there's fathers of everything and mothers of no one, because you didn't let women into medical colleges, but we'll keep that for another call. But he very famously said that medicine is a social science and politics is nothing but medicine on a large scale. And I think this pandemic and the way everyone has responded to it, politically, government-wise, healthcare facility-wise, I think it really shows the truth of, he kind of hit upon something very, very true. That the way you respond to a pandemic like this has a lot of political overtones and undertones and, intricacies in which women's health and particularly safe abortion access is still getting trapped within the politics of all that. So how do you, if you had a chance to speak to our politicians or to people who make health care policies, or even to healthcare providers, as Riti said, if you get a good doctor, you may still get access. It shouldn't be a roll of the dice. It should be something that you expect to receive because it's your right. It's your right to dignity, it's your right to health, it's your right to benefit from scientific progress. So how would you like to, what messages would you like to give for healthcare providers, for health policy makers, for people who are assigning budgets and deciding what goes where? Is there anything in particular that you know, as a takeaway? So in the post-pandemic world, what would you want the new normal to look like? Does Corinna, do you want to say something?
Yeah, I think to sort of highlight, as Polly mentioned, what good telemedicine has done in terms of easing abortion access and the positive feedback that they're getting from that. Because the feeling is that once we're post-pandemic, whenever that is, if that ever truly happens, there will be a pushback to go back to the way that abortion provision was prior to COVID-19. And so I think it would be just to highlight, firstly, what a common procedure this is. 1 in 3 women in the UK will have an abortion by the time they're at the end of their reproductive lifespan. So it's probably the most common procedure that anyone, regardless of gender, will undergo. And so to sort of pay attention to that, and also to look at, as we mentioned before, the fact that everything has to go back to government and the extra layers of regulation, to really look critically at what they add. Because we always say in Doctors for Choice that decriminalisation isn't deregulation. Right. So it's not suddenly going to be that anyone and everyone can provide in any way that they want. There will still be medical guidance in the same way as there is for every other medical procedure in the world. So just to sort of critically look at that and remove as many barriers as you can to providing not just abortion provision, but wider sexual health, reproductive health provision. There are lots of barriers in England, Scotland and Wales for wider sort of access to contraception, which some of them are linked to the abortion provision, some of them are slightly separate. But I think to look at the importance of all of it, look at how commonly it's required, and to just trust pregnant people to make their own decisions, and that if it's a decision that is their own choice and they're not being coerced, then what is our role as a healthcare provider other than to support them to complete the decision that they've made?
Absolutely. And a lot of the stigma really does stem from the stigma around sexuality and this sort of fear, particularly of young women's sexuality. There's this fear which also I think blocks comprehensive sexuality education, access to contraception, abortion. It's all kind of along the spectrum. And while I was going through medical college and even post-graduation, none of these political issues were ever a part of our conversations, or even, like not even the furthest spectrum of our concepts around these issues. And the more I got into this kind of development world, I realized that this political conversation is actually the most critical one to have. The biomedical and technical one can pick up anytime, but the social determinants and the political conversation is really what gives us the position of so much strength and power. So thank you to all of you, and we hope to continue conversations with you further. As Corinna said, we don't know when this pandemic and this situation is going to end, but hopefully at some point it will, and we may take the chance to have a conversation afterwards to reflect on what we felt as it was going through and what the new normal looks like now. So thank you all very much, and we hope to catch up with you again soon.
Thank you.